Sjogren's syndrome, Takayasu arthritis, spondyloarthritis, lupus, and infection-related rheumatism. He is currently, as everybody knows, the president of APLAR and is the immediate past president of the Indian Rheumatology Association and immediate past editor-in-chief of International Journal of Rheumatic Diseases. So his title presentation today is the evolution of criteria for early rheumatoid arthritis. So Debashish, please start your lecture.
Thank you very much, Professor Takeuchi, Professor Janguli, Professor Atikul Haq, and all the attendees. I would like to share my slides now.
Yeah, we can see. That's right.
Thank you. So the early rheumatoid arthritis is something which has been responsible for improving the outcome of rheumatoid arthritis. Detection of early rheumatoid arthritis is equally important as the policy of treat to target, as well as the newer therapeutic agents. So I'll be talking the topic under the headings of what is early RA, when does early RA start, why is it important to diagnose early RA, how is early RA detected, and where are the early RA criteria relevant. So what is early RA? If we go by the history, you will see that it was initially considered years back of less than 5-year duration of RA as early RA. But by early 1990s, it was decreased to 24 months or less, with greater emphasis on the first 12 months. And not only that, eventually, the concept of very early rheumatoid arthritis, or VERA, was defined as a disease with symptoms of less than 12 weeks. Now, when does early RA start? So these are the standard stages of RA, which has got a genetic susceptibility or genetic risk factors. There are environmental risk factors like smoking, the phase of systemic autoimmunity, where there is predominantly production of autoantibodies without symptoms. And then there is a stage of symptoms without any arthritis. After that, there's a phase of undifferentiated arthritis followed by full-blown rheumatoid arthritis. Some people would like to merge them, genetic and environmental factors, as one phase, of phase 1, asymptomatic autoimmunity and inflammation phase as phase 2, and we have the signs and symptoms of undifferentiated arthritis as phase 3, and the full-blown rheumatoid as phase 4. And at every stage, there is a possibility of preventing the initiation or progression of autoimmunity by removing the risk factors like smoking and other factors which are modifiable. Similarly, between asymptomatic phase to symptomatic undifferentiated arthritis, it can be prevented by various modifications, including the risk factor removal, as was possible in very early stage, pharmacotherapy, and induction of tolerance if it is feasible. And eventually, it is predominantly the pharmacotherapy which has role to play in preventing aggressive deforming arthritis. So next question is, why is it important to diagnose early RA? So this is a very nice review by Professor Paul Emery, who had compiled all the data available almost 2 decades back and mentioned that most patients with synovitis of more than 12 weeks duration do not resolve spontaneously, and the earlier treatment is started, the better is the outcome. And also the 1987 ACR criteria did not perform very well in detecting early RA. So these were some of the studies between from the year 2000 till 2010. And all the studies, I'm just going to highlight what they have concluded. So shorter duration, better treatment outcome. Treatment initiated after 15 days versus 123 days of diagnosis caused improved 2-year outcome. This group has shown that single drug induced remission is rare if initiated after 4 months of symptom. And this group had shown RA with 3 months duration has better outcome than 12 months of RA duration with similar therapy. Again, people have shown early treatment of less than 1 year duration causes less radiographic progression than disease which is late of more than 1 year duration. Subsequently, people have shown that biologics with 2 to 3 years have better outcome than compared to those where the biologics are initiated after 2 to 3 years. So treatment starting within 2 to 3 years with biologics has got a better outcome. Sustained DMARD-free remission is associated with shorter symptom duration at initiation of symptom. And if you have treatment started in less than 3 months of onset of symptoms, is associated with DMARD-free remission and less of joint destruction. So all the studies have again shown that earlier the treatment started is better the outcome. Now, how to detect early RA and how did the early RA criteria evolve over the years? So this was again one of the earlier study, and they have again the principles of evolving early RA criteria is based on the same principle of genetic and environmental factors, which continues. There's a phase of early inflammatory arthritis followed by a chronic destructive arthritis due to antigen presentation and T-cell response. And therefore, based on this principle, the older criteria were revisited. So this is a very old criteria of rheumatoid arthritis where RA was classified as possible or probable even. And what was felt is this criteria was too loose, and because of that it was too sensitive, but it was not sufficiently specific. So therefore the ARA, which is the older name for ACR, had formed a subcommittee in 1983 to revise this criteria. This is the 1987 criteria, which we have used till recently, and even now some people still use it in practice. And what was found that this ACR criteria of 87 provided a relative risk of 20 with sensitivity of 88% and specificity of 73%, performing better than rheumatoid factor alone, which has got a relative risk of 11.4. So this study was applied to 135 patients of RA with a shorter disease duration, and they found that this performed well in predicting persistence of disease. And what are the approaches in defining early RA? One is this what I have just mentioned is the predicting persistence. Other is predicting the development of erosions, and the other is predicting the development of disability. Now, predicting the development of persistence is one of the most practiced parameter to define early RA. It was shown by Paul Emery's group that 10 years of early arthritis clinics experience from a retrospective cohort of around 300 patients, they found that more than 12 weeks of symmetrical small joints arthritis formed a group with persistence approaching almost 100%. So if there is a symmetric inflammatory small joint arthritis lasting for more than 3 months, there's a high chance of developing chronic deforming arthritis. And that too, the persistence, if it is more common in small joints, especially the MCP joint, it is even more important in predicting the deforming arthritis. So in the year 2002, all over the world, several early arthritis cohorts were established from Netherlands to UK, Finland, Denmark, US, Austria, US again, UK, France, Norway, Netherlands. So various countries had early arthritis cohort which was compiled by this group, and you can see that from the 0 point of arthritis till up to about 1 year, in 1 or 2 series, 2 and 3 years were compiled, and they have studied the characteristics of the patients of the various early arthritis cohort. So using that, and eventually the first attempt was made by this group to diagnose early RA by creating a kind of prediction model. So they have chosen 7 variables, namely symptom duration at first visit, morning stiffness for more than 1 hour, arthritis in more than 3 joints, bilateral compression pain in the metatarsophalangeal joints, rheumatoid factor positivity, anti-CCP positivity, and persistence of erosions. And what they found is the ROC AUC of the model was 0.84 for discrimination between self-limiting arthritis versus persistent arthritis, and 0.91 for discriminating between persistent non-erosive versus persistent erosive arthritis. And the discriminative ability of the ACR 87 criteria for RA was significantly lower with a ROC AUC values of 0.78 and 0.79. So this model or prediction model seemed to be performing better. So this model actually had 3 components. The model one was developed by entering all the diagnostic variables, which I mentioned, the 7 variables, and except the genetic typing. So model 2 has 8, that is the 7 clinical criteria which I have mentioned, as well as the DQ HLA homozygosity. And the model 3 was made based on the non-modifiable variables like the gender, RF positivity, radiographic erosion, DQ homozygosity. So these 3 models are then applied, and patients have followed up for 2 years for whether the outcome is self-limiting arthritis, or is it a persistent non-erosive arthritis, or is it a persistent erosive arthritis. So this model have interesting outcome. This AUC ROC curves show that this 7 criteria model can discriminate persistent disease. It can also discriminate erosive disease. So you can see model 1 and 2, which is 7 criteria plus or minus the genetic factor, and model 3 is the purely objective, non-modifiable criteria. You can see 1 and 2 has performed better than the criteria 3. So the set of 7 criteria, even without the genetic criteria, without the other objective criteria, did well, and they had given weightage based on the odds ratio to calculate a score, and these 7 criteria then eventually were used. So using this prediction model, one could actually predict the outcome in the form of persistent erosive arthritis versus persistent non-erosive arthritis versus persisting self-limiting arthritis. So this was in a hypothetical situation where it was applied to a hypothetical patient presenting with arthritis in 4 joint groups, symptom duration of 2 months, and all other criteria of the model was negative. And using this model, what was found at the end of 2 years, this was expected that 2/3 will be self-limiting, about 30% will be non-erosive persistent, and only about 5% would be persistent erosive. And this was therefore a very good model which was applied, and this was found that even in if you apply it in real life, it could predict the outcome of RA. So they have concluded a diagnostic criteria set of RA was developed, characterized by excellent ability to discriminate at the first visit between the self-limiting, persistent non-erosive and persistent erosive arthritis. The set is very easy to use and it generates clinically relevant predictive values. New and easy diagnostic criteria set was proposed. Now in 2005, this is again a very interesting review and summarizing all the publications then. And what was the most important practice point that came out of this is that more than 6 weeks of arthritis, rheumatoid factor CCP positivity together can predict persistent or erosive disease better than 1987 criteria. Then came the era of imaging. This is a beautiful review by Mikkel Ostergaard, and you can see here the various imaging pictures right from a plain radiograph to MRI to ultrasonography. And you can see apparently normal looking bone, how it appears in MRI, showing significant erosions, and similarly in ultrasonography. So the Danish Rheumatism Association then had came to some conclusions, and this is that both MRI and ultrasound is important for suspected inflammatory arthritis, undifferentiated arthritis, difficult rheumatoid arthritis, to assess treatment response, to assess tenosynovitis and enthesitis. So this is the usefulness. And they have also found that when there is a suspected but not definite inflammatory joint disease, to determine presence or absence of synovitis, tenosynovitis, and enthesitis, this can be used. Early unclassified inflammatory joint disease to assist in the differential diagnostic process. Also, these modalities are useful. You'll be hearing on ultrasound from Professor Kondo after my talk. They have also concluded clinically difficult RA cases to assess disease activity, as well as to confirm or exclude a satisfactory therapeutic response. They are important. So both ultrasound and MRI are applicable in these scenarios I have mentioned. How about MRI alone is very good for early RA, for prognostication, and to establish baseline for destruction. So this is another, as well as the ultrasound alone is useful probably more often when you need to do aspiration, injection of joints and tendon sheaths and bursae. So patients with an indication of invasive procedures like injections, ultrasound is even more superior. Now comes 2007. So this is the early rheumatoid arthritis. review. And again, the same susceptibility factors of genetic and environmental factors which control the onset of inflammatory arthritis towards persistent inflammatory arthritis, which can be seropositive, seronegative rheumatoid arthritis, or just seronegative undifferentiated arthritis. So the targeting early arthritis helps. This is an example. So this study had shown that if you stop smoking, the production of anti-CCP antibody as well as other complications becomes much less if one stops smoking. So this is the role of how interventions in early disease help. Also, the tight control of disease, if it is done, even the conventional therapy going by treat to target concept using scores like DAS20, and now there are better ones, one can have a better outcome in terms of treatment. So the APLAR recommendation for the management of early arthritis was done, and it was a report of a task force of the European Standing Committee for International Clinical Studies, including therapeutics. So what they have come out with these points, one is that ultrasound for synovitis should be done. MRI for erosion is important. Prediction model for erosive arthritis should be developed. The study of steroids for early RA should be conducted. Biologics in early RA for prolonged remission should be explored. So in 2010 came the new criteria of ACR-EULAR, which was based on the joint involvement, the serology, acute phase reactant, and duration of symptoms with weighted scores given for different categories of involvement. In 2011, people have also described again that the very early RA or VIRA can predict major outcomes in terms of remission and radiographic non-progression. So VIRA disease was the only predictor of ACR remission, and only independent predictor of erosiveness was not having a VIRA disease. So if patient can present with very early rheumatoid arthritis, this is the best therapeutic opportunity in clinical practice to achieve remission and to stop the erosive course. So there is a clear-cut role of the 3-month symptom duration as the possible window of opportunity to improve the outcome of RA. And the need for better classify and diagnose early RA and very early RA continued, and therefore people felt that there is a need for better classification criteria. The 2010 ACR-EULAR criteria and the EULAR treatment recommendations for RA and the EULAR recommendation for management of early arthritis focused on early disease, and it translates the knowledge related to early RA into classification and management. So there was still scope for improvement. That's what everybody felt. So the evaluation of the early 2010 criteria was applied to various patient cohorts with symptom duration between less than 3 months to less than 2 years. And people have followed up for a reasonable period. And what was found in all these studies that the diagnosing early and treating early probably has a better outcome. However, what people have noted by using ACR-EULAR criteria, the specificity varied between different cohorts between 21% and 86%, and sensitivity of between 58 and 91%. So the ACR-EULAR criteria still did not meet the requirement of good sensitivity and good specificity in terms of detecting the early RA or the treatment outcome or long-term outcome. So there was a proposal to advance the classification criteria, and people have suggested to replace rheumatoid nodule with ACPA as a criteria in the 1987 classification criteria, as well as instead of RA, better to use undifferentiated arthritis when the diagnostic term is not very clear and needs follow-up. So there's also people who recommended the use of visual analog scale should be continued, use of undifferentiated arthritis as diagnosis in doubtful cases must be used, and use of prediction model and use of imaging techniques are to be recommended. So in 2012, the treatment strategies in early RA and prevention of rheumatoid arthritis, this study was published, and they have all recommended that DMARDs should be started in 3 to 6 months of symptoms in inflammatory arthritis. And this is the optimal time and window of opportunity. So again, the same picture, it shows that the early treatment is the key to delay or prevent persistence or erosions. So better outcome treating less than 3 months disease than more than 3 months disease, less than 1 year disease than more than 1 year disease, and less than 2 year disease than more than 2 year disease. In 2013, there was a study on bilateral evaluation of hand and wrist in untreated early inflammatory arthritis, a comparative study of ultrasonography and magnetic resonance imaging. And it was shown that MRI was the most powerful predictor of progression towards RA. In patients with ultrasound joint and tendon count of less than 10, MRI can improve the diagnostic performance of the 2010 classification criteria. However, when the joint count was more than 10, it was not as successful. So MRI was found to be superior to ultrasound in early rheumatoid arthritis, and they found that this could detect higher prevalence of synovitis in comparison to ultrasound in early RA cohort. MRI also revealed a significantly higher diagnostic capability. MRI and ultrasound, when they compared, they both performed better than 1987 criteria, and MRI was actually better than ultrasound when the number of joints affected were less than 10. In 2014, there was also a study on looking at the specificity and sensitivity of the APLAR criteria by a systematic review. So the black diamonds are imply specificity and the white ones are sensitivity. So what we can see here, that the 2010 criteria has lower specificity using any joint count system, whether it is a 28 joint count, 44 joint count, or 66 joint count. The specificity was lower compared to by any of the joint count system, and sensitivity was, however, somewhat better. So when it was compared with 87 criteria, again the 2010 criteria was performed better than, with better sensitivity than 1987 criteria in terms of sensitivity. However, 1987 ACR criteria had a better specificity than 2010 criteria. So the new URA criteria was proposed from China, and in that initial validation of the new ERA criteria in the Chinese population was done, and this was based on a simple 5 clinical features as shown in this slide: morning stiffness, more than 3 joints, arthritis of hand joints, RF, and CCP antibodies. And this are weighted by regression coefficient with scoring, approximate scoring, and it was found that this new ERA criteria fared better than both 1987 and 2010 criteria. So the new ERA criteria has high sensitivity and specificity. In 2016, the new ERA criteria was compared, and it was found that the sensitivity of the ERA criteria was much higher than 87 criteria. Specificity also was comparable to the 2010 ACR EULAR criteria. The new ERA criteria performed comparable in terms of sensitivity or better, whereas the specificity was probably little less than the 1987 criteria. So 2019, this study was further expanded for validation of a new for this new criteria in an international multicentric study. And this was published, and as you can see the evolution of the criteria from very early criteria to the latest criteria. And as we have shown that the initial validation was already done, and it has a reasonable sensitivity and specificity in Chinese population. So the intention was to study in comparison with 87 ACR and ACR EULAR 2010 criteria in a multicentric study. So about 400 patients from China, about 91 from Sweden, 116 from India were studied and looked for sensitivity, specificity, positive and negative predictive value. And the study study looked at the concordance of all the three criteria and compared all the three. And the demographic parameters on all the three cohorts are similar. However, the bone erosions were slightly less in the Chinese cohort. And overall, ERA versus non-ERA criteria, the common parameters are significantly different as expected. And the ERA criteria had a higher than 87 criteria in terms of sensitivity and similar to 2010 criteria. However, the specificity was slightly lower than 1987 criteria, but it was comparable to 2010 criteria. And so this is the comparison of the AUC sensitivity and specificity between the three criteria. And so the ERA was better than 87 criteria in terms of sensitivity, similar to ACR EULAR 2010 criteria, whereas in specificity, it was slightly less than the 1987 ACR criteria and similar to 2010 criteria. So the comparison in all the three cohorts, actually the AUC of the ERA criteria was higher. So in all the three cohort we looked at, and we found that the overall it had shown a better sensitivity. And when you compared the three cohorts, ERA criteria performed better in seronegative patients also. So we also compared to 87 and 2010 criteria. So when it was applied to seronegative patients, it performed better. When it was also applied again to very early RA, again it performed very good in very early RA patients of less than 3 months duration. So the concordance was, as you can see, that it has got a very good concordance in terms of sensitivity and specificity. So ERA criteria possibly can be used in routine practice. It has better performance across various ethnicities and seronegative versus seropositive rheumatoid arthritis in early RA diagnosis. ERA criteria had good concordance with 87 criteria and 2010 ACR EULAR criteria, and could identify patients more often. Now, what are the classifications? Why are they relevant? Where are they relevant? So this is an interesting study to study patients with only arthralgia who has MRI showing showing changes. So this is the phase before they develop full-blown arthritis, and MRI showing synovitis, but there is only arthralgia. Patient do not have clinical arthritis. So this study is now ongoing, and this study will probably hope throw some light on it. And it has a 2-year blinded period and 5-year open follow-up period. And this study results are awaited. And so I would like to say, based on the available data, that the detection of early rheumatoid arthritis and very early rheumatoid arthritis is important in improving outcome. MRI and ultrasound are adjunctive tools in detection of ERA and very early rheumatoid arthritis. And new ERA criteria developed by the Chinese group is validated. It can be used in routine practice. Thank you very much.
Okay, thank you, Professor Danda, for this nice talk on early RA. So from the definition, evaluation, and the treatment of ERA, so really it's a comprehensive talk. I think it's the best talk to me on ERA ever. So learn a lot. So thank you, Professor Danda. We leave the question to the last after the 3 talk. Okay, now I would like to introduce the next speaker, Professor Yasushi Kondo. Professor Kondo is from the Department of Rheumatology, Keio University Hospital in Tokyo. He got his MD and PhD, actually double degree, from the same university, supervised by Professor Tom Takeuchi and Professor Kazuya Suzuki. He received several awards from the Japanese College of Rheumatology and some other award also. He has many publications and he received some grants from the association. Also, especially I would say is the grant in aid for young scientists, which suggesting his potential. So he so that all his CV is on screen. I wouldn't spend my time to read all the text here. So his talk today will be on the differential diagnosis of inflammatory arthritis from joint ultrasonic view. I think it's a very practical talk for rheumatologists. So please go ahead, Professor Kondo.
Thank you for the kind introduction, Professor Zhonggo Li. I'd like to share my slide now. Excuse me, can I share the slides? No.
You can see it, yes. Need a full screen.
But full screen is now showed another monitor. So
yes, right. So Prof. Kondo, you need to switch the screen around. We are seeing your PowerPoint, not the presentation view.
You might click on the up right corner.
excuse me, sorry. Just a moment. Okay, again, I try to. Can you see this, my slide?
No. We can actually see your slide, but it's quite small actually.
Quite small. So sorry. Right. You
might need to rotate your screen to to the landscape, because right now your screen is portrait.
Yeah, now now I turned off my another monitor, so I would like to again share my slide. I'm very, very slowly. Is it okay?
This is good now. This is good. Thank you very much.
I'm sorry for late. It's very technical incidents. I'm sorry about that. So thank you very much, Chairman, and thank you for the great opportunity to give a presentation on World Arthritis Awareness Day webinar. I am Yasushi Kondo from Keio University, Japan. My topic is differential diagnosis of inflammatory arthritis from ultrasound view. Professor Danda kindly talked about usefulness of MRI and ultrasound. So now we would like to talk technically a point of the ultrasound in inflammatory arthritis in differential diagnosis. So this is the summary of my presentation. The first, ultrasound can sensitively detect early arthritis, but ultrasonographic arthritis is not rheumatoid arthritis. That is important. Ultrasound helps physicians to make a diagnosis via reclassify a distribution of joint involvement and clarify which part of joint are affected. The ability of MSUS in differential diagnosis is truly demonstrate in combination with medical history, extra-articular manifestation, and serology. That's important. So first, why we focus on the recent imaging modality, joint ultrasonography. And now in 21st century, as you know, the paradigm shift of RA treatment has been provided by biologics and JAK inhibitors. So the treatment target of RA is now early remission and change from care to cure. To achieve the treat to target strategy, the early treatment intervention is important. However, radiography, that the main image modality in rheumatology, can detect structural damages, but it cannot directly visualize the synovitis itself and tiny bone erosion in early stage of rheumatoid arthritis. So the paradigm shift of RA treatment make paradigm shift of imaging in rheumatology, because ultrasound and MRI can detect subclinical information even in early stage of RA. Those modalities has been brought to attention currently. So, okay, now let us review about MSUS imaging. Musculoskeletal ultrasound in rheumatology used to evaluate most musculoskeletal tissues, even not only synovium, detect not only anatomical changes, but also qualitative abnormality, such as blood flow. So ultrasonography for rheumatic diseases, in summary, useful to detect early arthritis and low cost and good accessibility, and improve the accuracy of interventions, as Professor Danda told a former lecture. Joint ultrasound can help daily clinic work being referred to as stethoscope or extended fingers. So now we would like to share what can be seen in musculoskeletal ultrasound. You may appreciate here, upper is ultrasound images of MCP joint, lower is corresponding histology of MCP joint. Here, this is a jelly layer. The first line is a skin. Then we can find the metacarpus, a proximal phalanx here. Then in ultrasound, the ultrasound reflect to the bone surface, so ultrasound cannot observe the internal part of the bone. And this arrow shows the extensor tendon. This is the extensor tendon. So where is the joint cavity? Is here? But no, this is hyaline cartilage. As you can see in the histological pathological finding here, then the cavity is here. We cannot observe in healthy MSUS findings in MCP joint. So that if the RA patient joint cavity is expanded by the proliferated synovitis, but the healthy control cannot be observed the joint cavity. So MSUS visualizes various pathological changes with good high resolution in the joint recess, synovitis, synovial fluid, bone erosion, osteophyte, tendon, synovitis, enthesitis, and cartilage loss and calcification. So why the MSUS can visualize various anatomical changes? The answer is US can generate high resolution images. Resolution of MRI depend on the size of coil. Indeed, the findings of the to find the information is maybe better than MRI is better than ultrasound, I think. But the resolution of MRI depends on the coil size. So in OA patient, you can appreciate here, MRI can detect the tiny information, but did not detect the osteophyte. On the other hand, ultrasound easily detect osteophyte with high resolution images. So next, we will redefine what is musculoskeletal US active synovitis. You might know that classically, ultrasound active synovitis is defined as a presence of synovial hypertrophy, in other words, grayscale, with hypervascularity detected by power or color Doppler. This is by MCP joint. Here is a RA patient. So today, now we discuss about this patient. Which patient have more active synovitis? Case 1 in RA patient on MTX 10 mg per week. The case 2 is RA with the anti-TNF in agent. Case 1 and case 2 had clinically swollen and synovial hypertrophy can be seen by ultrasound. However, case 1 has hypoechoic synovial hypertrophy and tiny hypertrophy. The case 2 is hyperechoic and no vascularity. Maybe you might know that the answer is case 1 is more active, but why? To clarify the US findings and local inflammatory activity, we have recently reported that the association between ultrasound findings and local synovial fluid cytokines. For instance, in treated RA, synovial vascularity and echogenicity, in other words, brightness, associated local IL-6 and VEGF levels. Hypertrophy itself did not correlate synovial fluid cytokine levels. So next, additionally, we also perform ultrasound-guided synovial biopsy to directly clarify the ultrasound findings and histopathology. Finally, we confirmed that the vascularity and hypoechogenicity associated with lymphocyte invasion of the synovium. So in case 2, with the osteophyte and hyperechogenic hypertrophy, revealed the hypo-invasion of the lymphocyte that shows the inactive phase of the joint. So I'd like to say not only synovial hypertrophy and vascularity, but also echogenicity also are associated the synovial inflammation in rheumatoid arthritis. So now we share the definition of MSUS activity synovitis. Here goes the main part. Can we make a definitive diagnosis by only US active synovitis. So you may appreciate here what is their diagnosis. I would share the 4 cases. Indeed, the left 2 cases are also those have active synovitis, but the left one is RA, but the right side is SLE patient. The right 2 cases shows left side is RA patient, but the right side is polymyalgia rheumatica. So I'd like to say US active synovitis is not specific. We must combine the history taking, other physical examination, and serological marker is needed to make a final diagnosis. So that what US images tell us in differentiating inflammatory arthritis, the point is 2 points. The first point is reclassification of distribution. The second point is which joint part mainly affected, including non-inflammatory findings. So I'd like to talk about the first point, reclassification of the distribution of the joint involvement. Among the key features in diagnosis inflammatory arthritis is the presence of synovitis as well as the distribution of joint involvement. The value of ultrasound in identifying subclinical synovitis has been demonstrated by finding synovitis in asymptomatic joint of patient with early oligoarthritis that led to the reclassification of oligoarthritis as polyarthritis for many patients. I'd like to show you the 2 cases. As you can see, the left one, 32-year-old female rheumatoid factor positive and the CCP positive patient. At a glance, we can see the active synovitis here, but we focus on the 44-year-old female, just only positive rheumatoid factor. It is very difficult to identify the active synovitis just a look at. So I'd like to talk about the limitation of physical examination. 2 physicians checked the 44-year-old undifferentiated arthritis patient, checked whether arthritis or not. The red one is me. We found the active synovitis here, but my colleague, the green doctor, says that here both doctor said the positive of active synovitis, but the red green doctor shows that 5 MCP joint of the left side is positive. And when addition the ultrasound find additional active synovitis here. This is the same as a physical examination, but ultrasound find another active synovitis on the right side of the wrist, left side of the wrist, and 2 MCP joint of the left side. So we know about that. You may appreciate here. Ultrasound and MRI detect joint inflammation more frequently than clinical examination. The mean detection rate for synovitis at the hand and wrist was 2.118-fold versus US compared to the physical examination, and 2.20-fold for the MRI. Additionally, significant discrepancy are found between active synovitis detected by physical examination and ultrasound. From our data, if positive of enhanced MRI is gold standard of active synovitis, US findings are well concordant with the MRI, especially in the MRI MCP joint and the wrist, but not so between physical examination. Poor kappa value is shown that point. And you may appreciate here, this table shows the variability of active information findings between examinators. Ultrasound pan-Doppler, so good to excellent inter-observer agreement. There was a high level of inter-observer and intra-observer agreement from moderate to excellent for US synovitis compared to the physical examination. So the receiver operating characteristic curve analysis for the criteria scores revealed that the largest area under the curve with ultrasound curve, when we applied the clinical examination only in 2010 ACR EULAR array criteria, combination of the US is improved the accuracy of 2010 ACR EULAR criteria of array patients. That's the point. So we would like to talk about the next point, the feet joint part mainly affected. This slide summarizes the MS-US findings and differential diagnosis of the joint location. A lot of findings can be seen in the MS-US, but today I would like to focus tendon and cartilages. So I'd like to talk about the pathogenesis of RA and the spondyloarthritis. You may know that rheumatoid arthritis, primary joint synovitis is occur, then make a pannus, and bone and cartilage erosion is made, and periarticular erosion is occur after the synovial hypertrophy. On another front, in spondyloarthritis, the inflammation from the enthesitis is primary lesion of the spondyloarthritis, and cytokine and growth factor goes into the intra-articular lesion. The secondary synovitis is occur and fluid outside the joint, and the erosion site is mainly not periarticular region, but also enthesial erosion is occur in the SPA. So this difference of pathogenesis make a difference of MS-US images in RA and spondyloarthritis. We focus on the MCP joint arthritis from ultrasound. The left side is rheumatoid arthritis, the right side is psoriatic arthritis. The rheumatoid arthritis patient mainly joint synovitis, but the psoriatic arthritis patient shows the inflammation spread from the peritendon and the ligament. So the US visualize the main location of the inflammation that is can be useful to think a differential diagnosis. Ultrasound clarify the treatment target of SPA called jet skin, not only the joint, but also enthesis, tendon, skin, and nail. Today, focus on the enthesis on tendon. You may appreciate here, this is the various enthesitis in SPA. You can see here a quadriceps tendon insertion to the patella. This side showed the hypertrophy of the tendon and positive of vascularity here. And you can see the enthesial erosion and osteophyte called enthesophyte also find in the enthesitis patient. So now I would like to talk about the difference of the tenosynovitis and spondyloarthritis versus rheumatoid arthritis. This is the scheme of the flexor tendon of the digit. The digit contains a lot of functional entheses that compress that wake the compressed power or shear of the joint stress. So this is cannot be seen in the clearly by the MS-US, but we can see in the pathological findings in the MS-US. Difference of the tenosynovitis, rheumatoid arthritis, and peripheral SPA can be seen in this slide. Rheumatoid arthritis mainly affected the joint or tenosynovium. So the tenosynovitis can be seen in the rheumatoid arthritis here, but psoriatic arthritis is originally from the functional enthesitis. So the inflammation spread to the tenosynovium and also a subdermal lesion. So the inflammation can be seen in the subdermal area to the tendon, can be seen in the psoriatic arthritis. So that is called dactylitis. So enthesitis and the peritendon inflammation is specific, really specific in the spondyloarthritis. The answer is no. This figure showed a patient from CTD arthritis. The left one is Behçet disease and the right one is SLE patient. And also, this is a unique findings in the immune-related adverse event patient. This is the typical enthesitis, but this is not SPA patient, but also IRA patient. Some IRA patient shows the enthesitis. I'm very curious about the peri-extensor tendon inflammation on the MCP joint. This is primarily reported by the Italian rheumatologist doctor. This PDI pattern is very specific in psoriatic arthritis, but this is, the left side is indeed psoriatic arthritis patient, but right side of the patient is SLE. So I confirmed from my ultrasound KO cohort whether prevalence of the PTI in MCP joint in untreated inflammatory arthritis patient. The results were summarized in this table. The PTI pattern peritendon inflammation frequently observed not only SPA patient, but also connective tissue disease patient, including SLE or Sjögren syndrome patient. That's the one of the good point to consider the differential diagnosis by musculoskeletal ultrasound. The final part of my presentation, I'd like to talk about some kind of the cartilage lesion. I will talk shortly. Now, non-inflammatory findings also important in ultrasound. Because a patient usually have a query, where does the pain come from? But the active inflammation is not defined by the serological biomarker or even in the ultrasound. However, this ultrasound findings showed the 70-year-old female has a thinning of cartilage. This is a typical OA findings in contrast of my cartilage on the knee. To find the crystals is important to consider the differential diagnosis. Why does the inflammation come from? MSUS can uniquely demonstrate the differential crystal deposit and the chondrous calcinosis. You may appreciate here MSU crystal on the crystal deposit on the cartilage surface in comparison to the intracartilaginous CPP deposition. This is a specific findings in the MSU and CPPD. So this is the summary slide of my presentation. MSUS is like an entrance to consider differential diagnosis of undifferentiated arthritis patient. US helps physicians to make a diagnosis via reclassify a distribution of joint involvement and clarify which part of the joint are affected. But disease-specific findings are limited, so combination with the medical history, extra-articular manifestation, and serological marker is important to make final diagnosis of inflammatory arthritis. I'm sorry to some technical invasion. Thank you for your attention to my presentation. Thank you very much.
Thank you.
Is that okay?
Thank you. Thank you, Professor Kondo. It was such an excellent talk on ultrasonography use in differentiating various types of arthritis. Our next speaker is a very accomplished rheumatologist, Professor Jangoli, who is the immediate past, no, not immediate past, I mean, he was the past president of APLAR. He is currently the president of Clinical Immunology Society of Association of China, the honorary president of Chinese Rheumatology Association, and the, as I mentioned, the past president of APLAR. He is the chief editor of the Chinese Journal of Rheumatology, associate editor of IJRD, or International Journal of Rheumatic Diseases, that is the journal from APLAR, and he's also the associate editor of Clinical Rheumatology, Seminars of Arthritis Rheumatism. He has published more than 300 articles in peer-reviewed journals, including Nature Medicine, Immunity, Science, Cell, Annals of Internal Medicine, Annals of Rheumatic Diseases. He has received several national and international awards for his dedication to rheumatology. His research interests are the mechanism and immune therapies in RA and SLE. Professor Jangoli is an excellent rheumatologist, a great human being, and a great good friend of me. It's my great honor to invite Professor Jangoli, who is also the chair of the convener of the APLAR Rheumatoid Arthritis Special Interest Group, to deliver his talk today on therapeutic strategy and deep remission of rheumatoid arthritis. Professor Jangoli, please.
Okay, thank you, Prof. Danda, for the nice introduction. I was pleased to hear the first two talk from you and Dr. Kondo. The two are really it's a clinical talk. So my one, let me share my slides. Okay, can you? Let me see. So can you see the slides? Dr. Dana, can you see the slide right now?
No, not yet.
Not yet.
What happened? I click on the sharing screen already. Let me do it again. Not working. I realized something wrong with my screen here. It doesn't work. It doesn't work. So I can see this. Gosh, this is.
Or maybe if you can quickly mail to Stephen, he can share it.
Yeah, I can tell the sign is not moving. I know how to do it, but not working right now. I probably need to come back to the close and come back again. See, not working. So you might maybe can get some question and answer. I come back to talk. So Stephen, are you there?
Yes, Prof.
So I don't know. I know I cannot select the share screen somehow.
So is Dr. Kondo stopped sharing? Otherwise, it can't do it.
Sorry, what?
Have you stopped sharing the screen?
Stop sharing?
Yes,
No.
Prof Lee should be able to share screen unless his PC hang at the moment. Maybe what we can do is that meanwhile, Prof Lee, maybe you want to send us your slides, and then perhaps Prof Danda and Prof Kondo could move on to do some Q&A first.
Okay. Right.
Yes. How can I send to?
Okay.
Sure.
So
Can I
we have
talk?
some questions here. So here is a question to Professor Kondo.
Yes.
On musculoskeletal ultrasound utilization in inflammatory arthritis. Clearly that certain sonographic features such as synovitis are not specific to a particular diagnosis of inflammatory arthritis like RA and SPA, but it is useful in determining whether joint pain is a result of inflammatory or non-inflammatory arthritis. In your experience, can you get both sonographic evidence of CPPD and gout coexisting together in the same patient?
I'm sorry that the coexisting of the CPPD and MSU deposit is not experienced. Mainly MSU deposit patient is younger. The CPPD is older patient. I have never experienced the both positive patient.
Thank you. There's one more patient question for you.
Yes.
This is from Dr. Suryo Anggoro Kusumo.
From Indonesia.
Yeah.
Yeah.
And he is asking to ask you whether ultrasound abnormalities on some anatomical area are more specific to one type of disease compared to other disease. For example, is involvement of tenosynovitis of extensor carpi ulnaris is specific for RA, or is it more related to the structure involved?
Thank you for the kindly question from Dr. Suryo, a long time no see. And the answer is very difficult, but we think the ulnar side of the wrist tenosynovitis may be specific for inflammatory arthritis, but it doesn't specific for rheumatoid arthritis because the psoriatic arthritis can be seen ulnar carpi extensor tenosynovitis. However, the mechanical stress is typically occur in the ulnar radial side of the extensor. So the ulnar side of the inflammation is typical for inflammatory autoimmune associated arthritis, I think. Not specific RA.
Sure. So here's one more question from Dr. Sok Puti. The question is, I think it's, well, anyone can answer, either you or me. The question is, I have a patient, his age is around 19 to 20 years old. He has chronic left knee pain, no trauma history, and has effusion. Effusion fluid analysis is normal, and rheumatoid factor and CCP antibody are negative. He has a severe pain and he feels stiffness of the knee. Treated with painkillers, joint supplement, but still pain and stiffness present. How this patient has a juvenile arthritis? I don't understand this.
Yeah.
Can we try to give methotrexate for this case?
I think not. The point is she or he is a younger patient with the left side of the knee monoarthritis. With that information, that differential diagnosis is a crystal infection and some kind of tumor-like arthritis, such as PVNS or dendritic lipoma, also the differential diagnosis. I would like to ask the questioner which is the brightness or echogenicity of the hypertrophy of the synovium of his patient. So because recently I experienced the dendritic lipoma of the knee joint patient. His synovium is very hypertrophic, but a very hyper-echoic hypertrophy. So I consulted the orthopedics, then make surgery. Then we found the dendritic lipoma from the surgeon, then pathological findings. So maybe methotrexate is harmful for this patient. I would recommend the questioner to consult to orthopedics and do a surgery to make pathological findings to make a final diagnosis for him.
Absolutely. I also agree. I don't think we can decide on treatment of methotrexate in this condition, and probably in a monoarthritis, chronic synovitis, you need to do a biopsy. Maybe it's a good idea. The next question is again for you, Dr. Kondo. This is, should we use ultrasound to monitor the progression of arthritis? If so, how frequently would you recommend doing an ultrasound?
No, I didn't recommend using a musculoskeletal ultrasound for follow up the patient, because the ultrasound is a time consumption examination, and mainly if you follow the course, physical examination is enough to confirm the course of the recovering of the arthritis. That is also confirmed by the big meta-analysis of the Arctic study or TASER study. So we would like to not recommend to use the follow-up, to use the MSUS to follow the patient. Patient.
Here's again one more question for you. Can you comment whether we expect synovial hypertrophy on ultrasound to completely resolve when the disease settles, especially in chronic cases, and the increased vascularity in the surrounding periarticular tissue, does that settle too?
Thank you very much for the good question. The synovial hypertrophy in many chronic course patients did not disappear after they achieved the remission of the arthritic activity. We confirm those patients have a hyper-echoic and low vascularity synovial hypertrophy, then the low synovial fluid inflammatory cytokines. So they are still persistent, the hypertrophy, but that is not have an activity, I think. Then the periarticular vascularity is often seen in those patients, but I think that is not usually active findings of the joint, I think.
Thank you.
Okay.
Okay.
My slides are ready.
Okay, you can start.
Thank you.
Thank you.
Thank you. Okay. Right. Okay. Thank you, Kevin, for the support. So sorry for the technical problem. Let me. It's a big screen. Okay. So my talk today is on the therapeutic strategy and the long-term remission of rheumatoid arthritis. So next slide. I will talk from these three aspects: the aim of our treatment and the evaluation. The second will be the consensus and argument. Lastly, we'll talk on the strategy of RA therapy. So firstly, the aim of our treatment. Okay, so I think as a rheumatologist, we want to see the patients can be controlled by our treatment. So hopefully the patient can be like the picture on the right, not the patient on the left. So get a really different disability. So that's our hope. So the remission is very important for RA patients. So this is a study a while ago from my own country, actually by my group. So I realized the remission rate of RA is very low. So from here can see it's only like a 10.9% or 6 or 5% different, depend on different criteria. So next slide. Recently, we just finished a study across Asia Pacific region by the 17 rheumatology center from 11 countries. That's cover 2010 RA patients. Also, you can see from the bottom, the RA remission in this area is very low. So like 35% by and that's 28 ESR, 62 which is that's 28 CRP. The rest of the criteria show us only 30% to 17.1%. So that's the average remission rate. So meaning most of the RA patients are not in remission. So next slide. So this is to show the disability of RA in this country. From this study, you can see the rate of disability in RA is over 77%. So most of patients have different kind of disability in the real world. So it's really a big problem for us. Okay, next slide. So what can we do to kind of solve or improve the RA treatment? Okay, next. So now it's the consensus of RA therapy. Firstly, I think everybody in the rheumatology know the EULAR recommendation for RA. Here, I actually want to share my view about the persistent remission of RA and when can we reduce the dose or withdraw DMARD. In this recommendation, it suggests the withdrawal can be taken, but didn't mention the time, say half year or 1 year, to really depend on the individual rheumatologist. Next. So this is the recommendation from APLAR. That's from several years ago. At that time, we realized when we talk about this recommendation, most of the member in the committee suggest the remission has to be over 12 months. Then we can consider tapering or discontinuation of the DMARD. So that's actually is also my own opinion for the continuation of DMARD. Don't withdraw DMARD too early. Next. So this is a study and actually from Professor Shed just suggests from many studies, if we withdraw the DMARD too early, even the remission in half, like 6 months here, you can see on the right, the almost half of the patient will come to like a flare of the disease. So half a year from this study probably is not enough for probably, I think, say most of the RA patients. You need a longer time for remission, then withdrawal, or the reduce the dose of DMARD. Okay, next. From the stress study, we can see the if we tapering the TNF-alpha inhibitor too early, the flares will increase. You can see from the arrow we point here, early withdrawal is no good for patients. You need a relatively long time to keep patient in remission. Okay, next. Also from the JAK inhibitor study here to show the better seasoning date. Dose reduction will cause flare for the RA patients. From the upper left, you can see the in 48-week data, continue on 4 milligram and step down to 2 milligram, the percentage difference. So higher dose is better for patients in remission. Next. In this study, actually this is a recent study in JAMA published this year. So half dose of DMARD cause increase of the RA flare. See from the left panel, see half dose of DMARD is worse compared to the stable dose. It's better use a relatively longer time to keep the patient in deep remission. Okay, next. What about the steroid? From the recommendation here from EULAR. In the middle, you can see clearly when we consider the glucocorticoid withdrawal, here to use these steroids as initiation or changing of DMARD. Basically, recommend the steroids used at the early stage of the treatment. So that's with many discussion in the committee. So that's from EULAR recommendation. Okay, next. But from this study, actually also it's a big paper saying the maintaining low dose steroids is better than withdrawal in half year. In this figure, you can see the data is different, but I will say probably the condition of patients is okay in 6 months, but not necessarily in 1 year or longer. So I'll show you the data. So just in the next few slides. Okay, next one. So here, this study is showing no additional benefit from steroid for short-term or long-term control. So this really is different from the previous one from Lancet. Doesn't matter it's short-term or long-term. So the steroids doesn't help the outcome of the RA patient in this study. Next one. And now, see here to show the non-use of oral steroids at the baseline, which is a predictor of RA sustained remission. Meaning, if you give the oral steroids at the very beginning, it doesn't help long-term remission in this study. So that's the study from Korea. Okay, next one. So take the all the data together. Here, I would like to say glucocorticoid is beneficial to RA remission for short term, say to the initiation of DMARD, or if patient have flare, but not use the corticosteroid too long. Say in the ACL or EULAR generally, 3 months probably is the maximum for most of the patients. I think that's probably from most of the data you can see. Not like some study suggests you can use long term. So it had to be depend on the patient condition, whether we can use it or not, but long term is no good. Okay, next one. So finally, I would like to talk on the strategy of RA treatment. Here, the first strategy is a prolonged intensive treatment is better for RA remission. This slide is to show the Bolin remission is an associated factor for drug-free remission. You can see in the table here, Bolin remission is a good predictor for RA remission, meaning a deep remission is better than the like loose remission in the RA patients. Okay, next one. This study actually is from the my own group published a while ago, suggesting the prolonged intensive treatment we call the PRINT strategy can improve RA remission. So if we use the same regime and we compare the remission rate in 3 months, 6 months, and 9 months, the longer the duration give us a better remission rate, no matter it's good remission, moderate, or not. So it's a relatively longer treatment, relative intensive is better for RA in deep remission. So next. Also, the deep remission will give us a lower flares for this group of patients. Next one. Actually, this strategy was recommended by EULAR recommendation in 2016 update, suggesting to continue the effective therapy is better than stop earlier or reducing the dose. So longer the intensive is better in RA remission. Okay, next one. This slide shows the sustained remission, the time, how long is better. Here, the 12 months remission is an independent predictor for a 5 years sustained remission. Again, to show us 1 year probably is better for most of the RA patient. If you see the square, the red square data here, which is the 12 months remission, compared the above 3 line, that's the half-year remission. All the percentages are better in the bottom 3. So longer remission is better. So don't withdraw DMARD too early. Again, that's the same, the strategy compared to the few slides previously. Okay, next one. The second strategy to me is the individualized therapy. Here my own country, we promote the individualized therapy several years ago. Try to let rheumatologists to know we really need I should say effective and safe regime for each patient, depend on the prognostic factors, patient response, safety, and drug adherence. So patients need this kind of therapy to get remission. Next one. Here I would like to show the different the treatment for our patients. You see there are at least 6 options for our patients, but different patients need a different the kind of treatment. Some patients probably need 3 or 4, but some probably need one kind of therapies. So really depend on patient the condition. We need to individualize the treatment. I put the surgery at the bottom. To me, I think we don't, as a rheumatologist, I will try to get patients improve, use different treatment rather than the other patient get like joint replacement or different surgery. This should be the last step for the patients. Next one. This is a figure, kind of a figure from the Kelly textbook of rheumatology, the 11th edition. Patient can be put on different drug, different medication, like a kind of a rotation strategy. I think no point to try the different one as this figure show. But we should choose the right relatively safe based on the patient condition and the effective medication. Choose the best combination for each patient for their own therapy. On the left, I show particular 2 medication. One is leflunomide. I know in APLAR area, some countries have this one. And in China and Japan, we also have the second drug, Rheumatoid, is also a demand in those 2 countries. We can use for our patients. Next one. This slide is to show the some patients, especially for the refractory RA patients, the individualized therapy is becoming more important. From the picture you can see them in the middle, some patient has the persistent inflammatory refractory condition, but some patients not in remission, but no inflammatory sign in the RA patients. By basic study, you know those 2 different group of patients has different immunological change in the joint or in the blood. So again, suggests individualized therapy are critical for patients. We have to analyze clinically and by lab study to see our image, like Dr. Kendall mentioned, to decide the therapy for our patients. Next one. So coming to this slide is to show again the different therapy for different patients. For that, like the anti-IL-6, tocilizumab is more effective compared to rituximab in the patients with less B cell in the joint from this study. So that's very important. So different patients using different medication, different biologics. So again, individualized therapy is important for the patient. So we need different examination to see the difference between different patients clinically, and also lab test. Next one. Next, okay. Here I just show you the one article published the earlier about the suggestion for disruptive innovation study, because the different RA patients have different immunological change in blood or in synovial. So we need to find new information in general or for individualized patients to decide what kind of therapy we can use for patients. Here to show we need more study to find the new, say, biomarker or the pathway. Then we can have a new method for different patients. Now, the major things in practical, the daily practice, some patients is very difficult to treat. So we need more therapies or new therapy also. Okay, next one. So here I make the conclusion from the three aspects. One is deep and longer remission of RA is challenging and should be the focus to me. I think for most of the rheumatology also to give patients the right treatment. And the prolonged intensive treatment of RA compromise with safety, that's the most, I think, important as a clinician. This prolonged treatment is an important strategy in practice. Disruptive innovation in RA research will show light to further treatment of the disease. Okay, I think that's here. I think this is the last slide already. One more, next one. No, okay. Here, thank you so much for the listen this the different slides, my opinion. Hopefully, we can have some questions to discuss. Thank you.
Thank you, Professor Ganguly, for such an excellent talk on deep remission in rheumatoid arthritis. I think now we can have the question and answer. So I think there are quite a few questions for you already. This one question is, what is the place of iguratimod in RA? I mean, is there any specific recommendation, or this drug can be used at any stage of disease?
Yes, this drug is available now, as far as I know, in China and in Japan. It can be used in any stage. If a patient is safe, there are no liver or some other serious problem. It's a quite effective drug in RA.
Thank you. There's one question for Dr. Kondo again. Can MSK ultrasound alone differentiate septic arthritis from other inflammatory arthritis? Do we need MRI for that?
Yeah, thank you for the question. I think it is difficult to distinguish the septic arthritis and other inflammatory arthritis. However, MRI is not needed. However, in my opinion, septic arthritis is easy to spread inflammation to or from subcutaneous or subdermal lesion from or to articular lesion, so that we focus on the musculoskeletal ultrasound to examine the septic arthritis. Focus not only in the joint, but also the subcutaneous lesion or other kind of extra articular lesion. That is important. Then do not don't be hesitate to procedure, aspiration procedure. That is important.
Thank you. I think that is all. I think we have. I don't think there's any other question here. Is there any other comment? Anybody, any of the experts, Professor Janguli and Professor Dr. Kondo, would you like to have any other comments?
So I would like to hear your opinion about this monotherapy and or combination for the patient who say a moderate condition.
Yeah. May I respond to that a little bit, Professor Janguli? I think it's a very relevant question. I have been practicing all along based on the initial recommendation of combinations are more efficient. The originally combinations came because, you know, like drug resistance in cancer, the disease modifying drugs also can develop drug resistance. So combination came something like that. And toxicity was not more than individual item. But there seems to be a newer trend now moving towards monotherapy. So I'm not sure. I think tocilizumab and JAK inhibitors are some agents who are probably recommended as monotherapy. I would like to listen from both of you, your opinion on should we switch over to monotherapy. And I think Professor Janguli is very important. You have given some very good message that, you know, persistence of remission is important and steroids are not beneficial in the long term. Those are some very great points you have mentioned. And I am not very sure yet about the long-term benefits of monotherapy. I think the Europeans are pushing for more of monotherapy now. So I would like to hear from Professor Janguli and after that, Dr. Kondo.
Professor Kondo, yeah.
Me first?
Yes.
Anyone.
Okay, thank you.
Sure.
So the very difficult question about that. So in our country, we have a national insurance for the treatment drugs. So we can easy to use biologics and JAK inhibitor. So that's why our country maybe the monotherapy of the biologics or JAK inhibitor maybe good for the patient in considering the cost effectiveness or keep a deep remission, in my opinion.
Professor Lee.
Okay. Actually, in my country here, I think for the patients, at the beginning, I say one patient using biologic, we usually recommend the patient use one CD mat at the same time. So that's the combination biotherapy and the biologic plus CD mat. Also, for some patients, probably we use like a methotrexate plus hydroxychloroquine combination. When patient come to remission, say for 1 year, we try to reduce one DMAT. Then see 3 months or 6 months, then reduce another probably. Again, the longer remission is better in long term. So that's my opinion. Yeah.
We have been using in our center for a very long time. Of course, in India, it's a different situation because most people healthcare is self-borne. The very little government support for biologics and not uniform everywhere. So we follow a triple DMARD therapy in the beginning, sulfasalazine, methotrexate, and hydroxychloroquine. And as you said, if the remission is for more than 1 year, that's a good sign. And then we try to reduce the dose. But very interesting to know from your data, what you have presented, is that if dose is made half, the chance of relapse is very high. So, so we also see that we very cautiously reduce the dose of DMARD if the patient maintains a remission or low disease activity for at least a year. And people who can afford biologics, yes, we do go for it. And we have all TNF blockers, tocilizumab and rituximab. JAK inhibitors had picked up very well here because we have those generic brands extremely cheap. But the problem is now the FDA has issued a double black label so I try to avoid in the elderly, little older side patients because the risk of thromboembolism and malignancy warning from FDA. So any opinion from you all on this?
Dr. Sando, you go first, maybe.
Sorry, and what is the point of the question? Sorry, what is the point of the question?
About the JAK inhibitors.
Yeah.
So recently the FDA has issued black label warning for JAK inhibitors. For malignancy and thromboembolism.
Yes.
So we have become little cautious in elderly people above 50 and all. So, but what is your opinion?
Yeah, very difficult about that. So the indeed the older patient, some patient is D2T RA. So the selection of the DMARDs only JAK inhibitor, the possibility of the rest of the DMARDs is JAK inhibitor. So in such case, we carefully talk about the risk and benefit of the drugs and use for those patients indeed. In Japan, maybe why is also methotrexate associated lymphoproliferative disease is a problem in Japan. So we usually carefully talk about the risk of malignancy for our patient.
Thank you. I think we have one last question. Again, looks like it is ultrasound related. On tapering biologic DMARDs after 12 months of remission, is ultrasound a good way to monitor for flare? Is there experience to share that there will be ultrasound features of flare earlier than symptoms or inflammatory markers? And would you act upon this?
Thank you very much for the question for me. Indeed, we have some cohort about remission patient follow-up after remission cohort, whether ultrasound is predict the flare of the rheumatoid arthritis. Indeed, some patient imaging remission is achieved. However, after a stop or cessation or treatment, relapse the activity of rheumatoid arthritis. But I'd like to say, if a clinical remission patient examine the ultrasonography, the positive findings of the power Doppler joint is risk of the flare of rheumatoid arthritis. That is confirmed by some study. So I would like to say the imaging remission, the usefulness of imaging remission is still unclear, but the persistence of the residual arthritis, even in the clinical remission, can predict a future flare of rheumatoid arthritis.
Thank you. I think with this, I will hand over to Professor Ganguly to conclude with whatever his comments.
No, actually, I have not much to add to this talk anymore. Here, I just would like to thank you so much, all the you and Dr. Kondo for the nice talk. And sorry for my talk, actually, the slides didn't go well, the technical problem, but I showed you all the data. So the nice discussion, I think we express our opinion about RA treatment. So all the three talk is practical, like I mentioned previously. I hope these webinars will really help our rheumatology to in practice. So that's just thank you again for your help in organizing these webinars in RA, and also thank the APLAR office to the support this seminar. Okay, thank you.
Thank you very much.
So
thank you then. Bye everyone. It was nice, very nice, Professor Kondo and Professor Jangoli for organizing this on the event of World Arthritis Day, Awareness Day. I think it was a great initiative. Thank you, APLAR staff also. Thank you.
okay, thank you everybody, people online.
Bye.
Also.
Bye.
Yeah. Okay, have a good weekend.
Yes, you too. Thank you, all of you.
Thank you.
Somehow my computer, I couldn't see myself clear. So dark, the background. Anyway. Okay, thank you, Dr. Kondo, Dr. Tenda.
Thank you so much.
Thank you.
Stephen, can close the recording?
We still have 100 online.
Oh, we still have 1 more minute left. Okay. Okay. Oh, this.
So Steven is still on recording?
Still recording. I think.
Recording stopped.
Stop. Okay.
Good.
Okay, just thanks. Actually,
Okay,
Dr.
Stephen.
For you, we have general. We had the general invitation from you, and for you actually for the
Yeah.
right? Hope we can accept.
Yeah, technical accident is very make it upset for me. The very difficult. Thank you very much for your kind support at all.
It was very nice.
Thank you.
Stephen, we'll make some YouTube recordings for this. We can make.
Sure, we can put some of these things up. But I will discuss with you. How do you want to do that? Yeah.
Sure. Maybe each talk can be, the main talk can be made into a YouTube recording. I think that will be nice.
We can do that, but actually, I would suggest that we put it on a server, on a video server, and link to our website, which will be safer rather than putting on the YouTube. Yeah.
Sorry.
Okay.
Is that lecture uploaded to the YouTube? Really?
No, I'm just suggesting. So he's normally not.
Usually for medical talk, we don't want to put onto YouTube. For security, and also, certain people might interpret what you say wrongly, especially the public. So we tend to protect it and put it on a website on a video server instead.
Actually, before you launch it, can we have take a look again?
Yeah.
Sure, no problem. Just that what will happen is that this particular webinar will actually be having video in demand as well. People can actually still go to the Zoom, register to view the video. Yes. So after that, we will then pack them into nice video for each speaker. We'll send it to you first for your vetting before we actually put it on the website. A new website will be coming out soon as well for the APLAR.
Thank you.
Okay. Yeah, thanks. It's better my one, so it didn't go well. It never happened to me before. Somehow It's could we get on? Can you see 90 the audience online? Is that true?
That's correct. There are still about 83 people online. They are right now quitting slowly. Some perhaps are still doing their survey. Some might have fallen asleep.
So only between the panel?
No, actually, they can still hear us, actually. Yeah, but just that many of them are probably no longer around, I guess. Yep.
Oh, gosh,
Yeah.
I said too much.
No, not to worry. Yeah. Sarah, try to help to remove the attendees. Thanks.
So it is 172 totally?
We need to generate the report. At any
Okay.
one time, maximum is about 180 plus. Yeah. So it depends on the number of people coming in and out. So we will do a post-event report for you to see the total number of people and across the different region.
Okay. Thank you for your hard work, Stephen.
No, at all. My
Okay.
pleasure.
Mm.
Yeah.
Bye then.
Hope we have more of such webinar in the near future.
Yes.
So can you like cut off the broadcasting?
Sorry, repeat your question again, please.
Just keep the talk between the panel. Can you do that?
Yeah, we are trying to move the people out. Just give us a little while. My staff is actually trying to move the attendees out of this platform. Just give us a little while.
I don't know the reason why. Okay.
Probably is the lighting.
Okay.
Yeah, because your behind is a bit brighter than your front.
Yes. I'll do it. Okay. Yeah, actually, not much to say. Do you have anything to like Danda, anything to say to us?
No, thank you. Thank you for agreeing to arrange it in a very short notice. That was good. Thank you. It was...
Yeah. Okay, then we maybe
Bye.
yeah. Bye.
Bye. Thank you.
Stop here. Okay. Have a good weekend.
You too.